Hodgkins International is honored Dr. Sholi is sharing his story as a hematologist oncologist, Hodgkin's lymphoma survivor. It's a first for us, as well as Dr. Sholi, as he's never shared his journey before today. I personally think couldn't have picked a more supportive group of I get it survivors. And luckily, we met through a mutual friend. We were connected. I have a new friend who is an old friend of Dr. Sholi. And it was just kind of kismet how it all worked out together. And then Dr. Sholi graciously accepted our invitation to speak today. And so now may I introduce to you Dr. Abdalla Sholi.
Okay, well, good afternoon, guys. If you're in Eastern time zone, if you're not, good evening. If you're somewhere else, or if you're in the Midwest, also good afternoon for that matter. My name is Abdalla Sholi. I am, as Kathy said, 33-year-old survivor of Hodgkin's lymphoma. As Kathy said, I never really shared it except for very close family members. Not every family member even, and you guys know how that feels. And very selective friends. I don't like, for some reason over my life, I was talking last night, one of my friends was actually battling through a different type of malignancy, that it feels weird to share that you have cancer with other people. I was, it's, and he has actually mentioned to me, it's like, we should probably try to cash up on it. It's like, oh, no, thank you, I'm good. So my story dates back to 1989. I can start telling you how it really happened and how it really ended. January 89, I just really did not feel very well for probably a few months. And I was in my second year in college. I wasn't really sure what's going on. I had this cold, I was coughing. And then and then over time, I remember I started having night sweats, profound itching, especially at night, and lost a ton of weight. I mean, I liked it. If you notice, I'm not a thin guy, so I thought it was great to lose some weight. But it wasn't really the right weight loss. I felt extremely fatigued and tired. I could sleep probably all day. And seeing multiple multiple doctors to see what the cough, multiple antibiotics. Finally, somebody had the brains to, which is I'm not trying to blame anyone, but because we all do, as in the medical field, we end up doing the same stuff. Somebody had a chest X-ray done, which showed a widened mediastinum, which is, if you look at the X-ray, basically the central part of the chest where the heart is. The mediastinum is the area above it, and it was a little bit widened. And it's like, that's kind of weird. So this kind of led to a CT scan, which showed some lymph nodes. And that led to a mediastinoscopy with a little bit of a cut in above the collarbone with the scope. Took a bunch of lymph nodes, just a multiple biopsies, and that somehow made the diagnosis. Obviously, during that time, I'm really very confused, and I was really angry because I'm going to have to miss school, and we all know how that feeling really. I was just angry. I was very, very angry. After the diagnosis was made, it was Hodgkin's lymphoma, nodulosclerosing Hodgkin's, and it was stage 2B. It was 2 groups of lymph nodes above the diaphragm, and had the B symptoms of the weight loss, the itching, and the night sweats. I had to drop out of school at least, or took a break, for probably for at least a whole semester. And my dad was very adamant you should probably go to England. Now, if you know anything about the history of the world, England, being living in Jordan at that time, Jordan has a very long and historic ties with England, and my dad's like, go to England. I'm sure they could have really, almost done the same thing in Jordan, but I'm glad we did. So I got to go to England and live there for a while, so which is pretty cool. I'm not rich, so we didn't have a house. Sorry, we knew somebody who was pretty well off, and they were very gracious to give us their house in London. Actually, they moved out of the house for us, which was astonishing to me, to be honest with you. I was 19-year-old and not feeling well. We ended up going to the Royal Marsden hospital in Sutton, Surrey, which is outside of London, by like 45 minutes probably. By train, probably half an hour. And the first time we went, we had to go by car, and one of our friends took us out there. Anyway, we go there. We had the consultation, and they had to do the workup. They had to do a bone marrow biopsy, which was, if you ever had a bone marrow biopsy, it was not the greatest thing in the world. Although I had two in my life, one when I was first found out in Jordan, and it was done by a resident. And it was one of the worst experiences I ever had in my life. I think I was screaming pretty loud. It was very painful, and it didn't show anything, thank God. So, but anyway, it was when I got to England, said we have to do another one, and I was just petrified. And this amazing RN did the bone marrow biopsy on me, and I literally did not feel anything, which was just beautiful, which is the best thing ever. They repeated the CT scan, reviewed all the slides, and they said, well, we're going to have, this is Hodgkin's lymphoma. And again, I did not have the medical knowledge yet. I knew it was some sort of a lymphoma, some sort of malignancy. I'm not sure what it means. And as any 19-year-old, I really I wasn't really that afraid. I was like, you don't care at that age, I think. I'm not sure how I felt about it. I think I was more angry, and it's like in my head, like I was really more concerned about how my dad had felt about it, because I thought he looked pretty nervous. Let me say that. So they elected to start me on what I understood from, if I remember right. Again, excuse my it's been more than 33 years. I think I was part of some sort of a protocol, and they gave me a combination of 4 drugs. Now, if you know Hodgkin's lymphoma in 80s, the predominant chemotherapy for earlier stage Hodgkin's was either MOP, or a hybrid MOP and COP, or BCOP if you're in Germany somehow. Or intense BCOP probably a little after that. ABVD came into the scene probably in the late 70s, became the standard chemotherapy probably late 80s, early 90s. But before that, it was either you get MOB, COB, hybrid, and with all the side effects associated with that, which we're going to talk about, some of those side effects, basically infertility and exposure to alkylating agents, one of those chemotherapy. And we went on a trial. It was 4 different drugs. I've never really, over the last 33 years, I've never seen any combo like that. I'm not sure what happened to that trial in particular. I think it worked, obviously. So because it was a combination of vincristine, etoposide, epirubicin, which is a different anthracycline than the doxorubicin that we use for ABVD, and prednisone. So the main thing is lack of alkylating agents. So there's no dacarbazine, none of those things. And it was epirubicin, which is a different anthracycline, which is a little safer than adriamycin. Etoposide was probably the most interesting chemotherapy of those. And vincristine is pretty standard for, you see in CHOP chemotherapy for non-Hodgkin's lymphoma, more than the ABVD. Anyway, regardless, I don't want to give you guys more of a scientific talk here. I think I did 4 to 6 months of chemotherapy. And it was, we lived in London and the hospital was outside of London. So I had the chemo, and then you go home, you take the train back home. And by the time I got home, it was just not a very good feeling. I threw up a few times, obviously. We all this is before the days of the very good and effective antiemetic treatment that we use now. I can't remember what they gave me. but it was okay. I threw up a few times, as I said. I was more concerned about my hair loss, to be honest with you, because I mean, don't get fooled. I used to have really good hair. It was really thick and nice. And after the first cycle, I noticed that my hair was falling down. I wasn't expected to fall that way. It was just, I think at one time I think I was taking a shower. I noticed that really half of my hair is in the tub. It's like, oh my God, what's going on? And every time I do this, and it comes in my hand, and it was starting to become obvious. So I made the conscious decision to go shave my head. So I went to a salon in London, and they were surprised, like, what are you doing? Like, I want to shave my head. And it's like, why? What's going on? And you have to explain to people, obviously, why you're shaving your head. I'm still mad at them, though. They charged me money for it, which is, I thought they should not have charged me money for it. It was like £20 or something like that. So anyway, I shaved my head, which was by itself was not the greatest feeling, and we all lost our hair at one point. I had a cap on, and at one point I had to wear a wig because my sister decided to get engaged in the process, and I had to go to my sister's engagement party, and I was wearing a suit, so I wanted to look, somehow decent enough. So as if the hair makes a difference, but convince a 19-year-old that somehow in a different way. So I finished the chemotherapy, and all the CT scans were fine. I did not really. I think there was either some adenopathy left, and this is before the PET scan days. So I'm not sure what's actually, if I remember right, if I understood, there was some left, little tiny bit of a lymphadenopathy. So I decided to do radiation, the mantle radiation afterwards, and that was done. That was actually interesting, because it was the smell walking into that radiation oncology department, which was, it's still in my head at this point. If I smell that, I'd probably throw up. It wasn't that nauseous, but it's a weird feeling, the feeling of laying on the table and it moves and up and down, and you have to stay still, and all that feeling was just it was just an odd thing. But I finished my radiation, and just before I finished the radiation, I came up with shingles, literally diffuse herpes zoster all over my body, out of nowhere. And I had to put me in a hospital because it was literally diffuse, like everywhere, like in my ear, like inside my nose. It was horrifying because it left some holes on my face, and I looked kind of. I still laugh at the. I think I took the subway to go to the hospital, and I didn't know what it was before I went to the hospital, and people were looking at me in a very odd way. Let me tell you that, and I don't blame them, but yeah, it was pretty interesting ride. They kept me in the hospital for 2 days. I think they gave me antivirals, if I'm not mistaken, and that started to go away. And then resumed the radiation a few days later once things kind of cooled down. Finished the radiation. The scans were excellent. And then now I'm done. I am supposed to be in remission. And then I had to leave England. I had to go back. I had to back home, and that's where the follow-up happens after that. You have to go, and I re-enrolled back in school, and I went on to enroll in medical school. And I can tell you, it's the you hear about the chemo brain. It is absolutely true, and could not be more evident for that first year after I came back. And honestly, I mention it to people today. It's like I really could not understand anything I was reading. Like I was reading a book. I was like, I can't understand what it is. It's like I'm not sure what I'm reading. I don't know. It just not going in. It was the weirdest experience, and I mean, my grades took a tumble, like a huge tumble, from really good grades to really poor grade. I barely passed the first year. Thank God it wasn't anything do with medicine, but it was so I finally kind of recovered from that. My hair started to go back to normal. It was short initially and then grew back, and my all my skin started to heal back from the shingles. And I was and from the radiation, my neck was kind of pretty burned, I would say. My skin was very sensitive. I was told to stay away from the sun for a while, so I avoided being in the sun. The skin was very soft. I had no hair for the most part at the bottom of my neck. It was almost like a gap from where the radiation was to it was just completely smooth, and even some of the hairline was pretty affected, and that was like that for years and years and years. And it finally, I think that I lost the rest of it, but I think my actual hairline came back before I lost all of it. I followed with local doctors at the university hospital, and it was weird because I was starting to go to medical school, and I know all those people. It was a very weird experience, where the people that examine you and looking for a large spleen, and it was an interesting thing. And I had multiple CT scans and I had all kind of stuff. And I mean, I have to say, I mean, things are pretty well. I did okay. I did not have any recurrent disease. It was a very rough couple of years because the anxiety post-treatment was huge. You wake up in the middle of the night and you're feeling your neck. You almost every time you sit down, you're trying to feel your neck. Do you have any lymph node? And you have the fear that you're not going to be alive for a long time, although it's not a realistic fear. It's in the back of your head, like this is going to come back and I'm not going to make it. And that lasted on. I mean, the further you are away from the treatment, the less it became, and less and less and less. And after 5 years, I kind of felt okay. It's over, and I don't have to worry about it. Obviously, a year later, I went back to England for further workup, repeated the CT scans, and they did the sperm testing, and it was fine. It did not affect my sperm count. And they said, you're okay, just follow with your local doctors, do scans, so and so. And they give me the instructions, what do I need to do? But beyond 5 years, nobody told me what to do until I was in my fellowship in hematology and oncology. That was in the early 2000s in Wisconsin. And I decided to go to see one of my local doctors, one of the hemonc attending. And he told me, well, you should probably do this and this and this. So we had a bunch of things done. This is pretty around like 13 years post chemotherapy and radiation. So I had thyroid function test, a MAGA scan for my heart. I had a lung function test, just regular blood work. And he's told me, you're fine, you're okay, you don't have to worry about it. And even then, in a university hospital, there was no established care. This is like in the early 2000s. And then a few years later, I did a few things on my own. It's kind of weird being a doctor because you end up your own physician for the most part, and you'll be your own advocate. And it's what I came to the conclusion of, that we eventually, most of us who are Hodgkin survivors, we've got to be our own advocates, because it's especially with the changing structure of the health system, and there's a lack of physicians, and a lot of the nurse practitioners and PAs are taking over a lot of the practices with not a whole lot of experience in managing complicated patients. I feel it's going to fall a lot on people like us, because they're not sure what to do unless we will become our own advocate. That's why I think we should probably be our own advocates on what we should look for, what we should do. Not everybody lives close to a place where there's a survivorship program. And I know some of you guys been to survivorship programs. Even survivorship programs, they can give you things to do, like this is what you're supposed to do. But you would think it'd be more intense than that, or more structured and more, but it's not. It's such a gray area in medicine. And again, I think the more we know, the more we could think we could do something about it, and we can talk about what we need to do after that. But that's in a nutshell how did I end up a long-term survivor of Hodgkin's lymphoma. I got married. I had 3 kids. They all look like me, so they're definitely mine. That was a joke. I have 3 kids. I have 2 boys and a girl, and none of them want to be in medicine, thank God. But yeah, they're pretty healthy. Yeah, I wasn't concerned about Hodgkin's being familial. That's not really a concern. By the way, I was the only one in my family with ever history of any sort of malignancy. And that's and here we are. So that you can ask me anything you wanted before we continue to the next slide. What do you guys think of that? Kathy, I can't hear you.
Okay, can you hear me now?
Yes, I can.
Well, you couldn't see it, but in the chat, and I'm sure behind everyone's screen, there were a ton of nodding heads. We were all in sync with you, especially, you know, with the bone marrow biopsy and the shingles. A lot of people had mentioned in the chat that they had shingles after radiation. I still
have nightmares about it. I can tell you that it was one of the worst feelings I had in my life. Back to the bone marrow biopsies, I just being an oncologist. And again, I did not talk about why did you become an oncologist, by the way. One of the things I've been trying for years is to do bone marrow biopsies under conscious sedation. The problem with that, you run with a lot of bureaucracy between the hospital, between having the space, the nurse with the anesthesia, the insurance companies paying for it. But you could probably get away with it somehow if but it's very time consuming because you have to have the physician who is willing to do it. Somehow most of the bone marrow biopsies in the year 2023 are becoming part of the interventional radiologist in a whole lot of places. I mean, you send them to the hospital under the CT guided, they see where the bone is, and they do it under CT guided. We haven't done a bone marrow biopsy in our office here at UPMC for a couple of years, although we have all the machines. We have the gun, the drill. Actually, we would have to do it our own, but we don't do them here. We just send them to the hospital. We had no ability to do conscious sedation in the office anyway, but that's something I used to do for years. And it makes life, the patient pretty much wakes up, it's like, are we done? It's like, yeah, we're done, we got it, you don't have to worry about it. But that was something that would be nice if we could. I don't know how we're gonna really make that more of a thing, but I can tell you, it really makes a difference in not suffering through a bone marrow biopsy. Why did I become an oncologist? After I finished my chemo and radiation and was in remission and began my medical school training, it became more of a goal. I think part of my I don't know if it's really my anger about it. I don't know if it was my dedication. I'm not sure what is it really, but I wanted to treat this. I wanna not Hodgkin's in particular, but any type of malignancy. And I that was my goal for really early in medical school, and that's what I wanted to do. And I was lucky enough to do it. And I have to thank a lot of people who actually helped me along the way without knowing what happened with me. One of the guy who used to be an old doctor in Scranton, Pennsylvania, he's in Philadelphia now. He retired. His name is Dr. Sal Cielo. He's one of my favorite people to talk to. He was an amazing person. But yeah, that was just nothing to do with anything. Just to mention his name.
Well, going along with the bone marrow biopsy, is there anything else that you do differently, or has it shaped how you treat your patients, your experience?
Yeah, I mean, it really wouldn't. So when you try to explain to the patient how you feel after the chemotherapy, unless you actually had chemo, you're not gonna be able to tell. Like, you really, because it's that little simple things that you feel that people do not know how to describe. So you try to tell the patient, this is really what's going to happen. You're going to have this. You're going to feel great today. You're going to feel fine probably tomorrow, and then you're going to feel like you hit a wall, and then you're going to feel really tired for a little bit, and then you're going to recover. You're going to be fine, and you're going to notice this and this and this and this. So it makes it more personal. Somehow it may help some people. The problem is also when you're in that situation as a patient, it's hard to take instructions from a doctor in front of you. You're not going to get most of it because you're overwhelmed, you're nervous. I think it helps though if you make the personal experience as a physician than being like from this is what's going to happen as to dictate to them. That's really not, doesn't help usually. And we give people a lot of information and papers and information about the medication, and I don't think anybody wants to read those papers. I read them a lot of times to get more anxious because the amount of side effects on those papers are more than the actual side effects. So there's no win situation, honestly. And also on top of it, everybody have access to the internet, which is, and everybody sees, which is a good thing and a bad thing sometimes, because if you're not sure what you're looking for, it's going to give you a really false sense of what's going on, and it's kind of hard to change somebody's opinion if they already made their opinion already. It's really hard. So it's always very difficult, I think, but it helps if you make it more personal. You can probably connect with people easier and make them understand the process. So to me, it's always personal, always personal. I don't want to really say that, but I really take it personal. Like I get mad, I get offended, I get like this is basically we can, and why it's not working, and it just it's definitely. I mean, I'm sorry, but I'm getting goosebumps, but I should not be saying that. But yeah, it's a very personal thing to me, and I could not be more satisfied in my life, to be honest with you, to do this.
Dr. Sholi, this is Erin. I just wanted to jump in here real quick and add to what Kathy was saying. In reading some of the comments, you have just hit, some very personal and memorable memories from folks, and just everything in terms of the smells, the clang of the heavy door, the drinking apple juice, losing your hair, shingles. And I don't know, I'm just curious myself. I may have missed this, but did you mention having a lymphangiogram at all? Was that
no, I thank God I got away like by like a tiny little I missed that the whole period of the staging splenectomy or lymphangiogram. I had CT scans, and I don't think I had a lymphangiogram. No, I did not. So
well, you would definitely remember it if you had it. It was right.
Oh God, yeah. Oh, I'm sure. Yes, I mean you read about those things in the books, and I'm very so happy and grateful it wasn't me, because I mean the few things that we did to people over the, well, it's not like because we did it on purpose, but it's the things that how the medical field evolved over the years is tremendous, including in those in a disease like that. It's obviously, yeah. But no, I did not have an lymphangiogram. No.
Okay, Dr. Sholi, also we had questions about if you had any radiation late effects.
Late effect, not yet. I think I am hypertensive. I started early in my late 30s. I think that's probably from the radiation. That's probably the cardiovascular side effects of radiation. I did not have any heart failure as far as I know yet, but I'm hypertensive, and it's not very nice hypertension either. So I think that's to do with the radiation personally. I have no thyroid problems. I do have xerostomia. I have very dry saliva, which caused me to cause a lot of dental workup. It really damages your teeth if you have xerostomia. And it does. I had a lot of issues with my teeth, and I think I still blame the radiation for that. I don't have anything to report yet. I had multiple lung function tests. It's okay, but I did not get really bleomycin, so I don't think it's going to affect my lung function. I was more afraid to the effect of the direct effect of the radiation on the heart, the esophagus, and whatever the reflection from that area to the lungs. And thank God it's not as intense yet. So beside the hypertension and the dry mouth, it's pretty much it.
Well, thank you for sharing that with us. Aaron, did you see anything else that came up? Let's see. Oh, there was one message that I don't know if you saw that.
I can't, I'm kind of hard to do all of it at the same time. So
Yeah, right. So this is the one that I'll bring up.
Yes.
Just as a comment, somebody made that it was heartbreaking that to hear you as a doctor say that we need to be our own advocates.
Yes.
And it's just so ironic, and that we need to advocate for ourselves.
I'm sorry, guys. I'm a doctor. I'm also I'm a patient. I'm human. Healthcare is not heading in the right direction. I'm so sorry. We're not right. There's something is not right about what we do. It's I don't know if it's really the insurance company, the privatization of the health system. I don't know what is it, but we're focusing on wrong things. We're not focusing on what makes people feel better. And you can see it. It's a practice medicine every day. You see this every day. It's very heartbreaking.
That you probably are going to talk more about this in the latter part of your talk, but that's certainly our mission at Hodgkin's International is to help people with the things that aren't working in terms of healthcare. And our focus has been on making sure that people understand late effects and that they get help. And what we've noticed is that there's a tremendous amount of research going on right now about late effects, particularly with Hodgkin's and non-Hodgkin's lymphoma.
Yes.
So there's a great deal of information. The hitch is it's not getting to patients. It seems to circulate amongst researchers, which is fantastic. But I can't tell you how many times we've, called for, the need to make sure that information gets beyond the research circles and into the hands of the people who need it the most.
It's very concerning because it's beyond the doctors in the research. It doesn't get even to the community physician, to community oncologist. It's not, it's not a standard part of what people do anymore. Right. Or I've been doing this for 20 years as an oncologist, and I can tell you. And I practiced in. I had a private practice, and in few areas, and I've been with UPMC now for the last 4 years, and we do have a survivorship program, but it's outside of that in the community. I don't think there's any form of that really. I don't think people even look for late effect. Once you hit 5 years, a lot of people let you go.
Right. Right.
And you're not going to find anything with your family doctor because half of the time you have like 15 minutes. And if you see a nurse practitioner who doesn't know you or a PA, I'm not against nurse practitioner or PA. I like those. They're excellent people. But I'm saying if you don't know you're not going to know what to look for, especially for somebody who had Hodgkin's 10, 15 years ago or 20 years ago. You're not sure what to look for. And it's an issue. A lot of those things that we're going to talk about in a little bit, it requires a lot of screening and thought, and you have to think about what you had, what you're supposed to do. So it's not as simple as, well, have your mammogram and have your so-and-so. And it's not just as simple as that. I think the heart disease, the different form of heart effect, which we are going to talk about, it needs more than just I'm not sure what the right formula, to be honest with you, how to get it everywhere. I'm not sure.
Well,
yeah.
We're working on it too, and we may tap you for help because that's just what you said is such a perfect start to our mission here. That's what we're after, is to figure out ways to get information to people. But Kathy, I don't know if Dr. Sholi wants to go on with his presentation. We have so many questions, and I'm sure comments, but we could take 3 hours to get this all. But I don't want to short shrift you on your presentation.
That's okay. I'm sorry, guys. I cannot read all the. Somebody was 1979. God bless you. Here you go. So is that the oldest survivor from 1979? We had somebody after that.
We
Gosh,
have people, there are several people on this call who, including myself, are more than 50 years out.
Oh, God bless. Oh my
Yeah,
God.
yeah.
Awesome. So
we
somebody
have-
asked me if I take a stand. I used to. I stopped taking it. And my cholesterol was never really that high, and I lost a ton of weight, and so I stopped taking it. And made me lose some hair. Again, I'm really focused on hair, if you notice. Not sure why at this point, but yeah, my cholesterol is not that bad. So I stopped taking it a while ago, and I want to drink alcohol also. So it it makes it easier.
Well, okay, well, maybe we should move on to the rest of your presentation, and if we have time, we can get back to some
All right.
questions.
So if you guys do not know this is Sir Thomas Hodgkin's. This is the English pathologist that our disease is named after him. He described a series of patients with a similar, if you could probably read the actual article, you can find it easily online. If you can understand half of the words in it, because it was in the 1800s. He died in late 1800s. He was a very distinguished scientist. Actually, he did a lot of work in cardiology, a lot of things. He achieved a lot of things. One of the most memorable things about Sir Thomas Hodgkin's is his final words. He said, "The little service I have done." I thought was amazing that actually he said that. I don't know how true this is, but that's what I saw. I wasn't there for it. So Hodgkin's lymphoma, you can call it Hodgkin's disease if you want to. I know people think so. Makes it less of a problem if you call it Hodgkin disease. But I tend to think that sometimes it calms people down if you tell them you have Hodgkin disease and Hodgkin lymphoma, and you're trying to explain to them that this is something you could probably be, most likely you'll be completely cured out of it. And that's why sometimes they call it disease. Sometimes it helps people, especially younger folks, to calm them down from the initial anxiety that they really show up with. But your Hodgkin, people do not die from Hodgkin's anymore as much as they used to do, at least. So the death from Hodgkin's levels off after 10, 15 years. That's even a little more extensive than we think it is. Death from other causes, most notably secondary malignancies and cardiac disease, that is mostly the most common late effect for Hodgkin's. And those continue to increase over time. There's other late effects like non-coronary vascular disease, like hypertension, cardiomyopathy if you use anthracyclines. A lot of time, if you don't know that, from the radiation, pericardial disease, valvular heart disease, vascular disease itself in the major arteries, and carotid disease if you have the neck. So a lot of non-coronary vascular disease is basically it's not just regular heart disease. It's a little more extensive than that. Pulmonary dysfunction if you had radiation, if you had bleomycin, xerostomia or dry mouth, pretty much, and that what caused a lot of effect on your teeth, and periodontal disease. Hypothyroidism, obviously, if you had radiation to the neck area, and that's something you have to keep an eye on, and your physician should at least do that anyway. I mean, ideally at 50 should have a TSH done every year without being in Hodgkin's. So I mean, I cannot imagine people with Hodgkin's who had radiation should have that done, at least more common. And fertility used to be more of a problem in the past. With the newer use of different chemotherapies, at least for the last 20 plus years, doesn't seem to be as much unless you had more intense chemotherapy, or you had a bone marrow transplant, or you had more extensive radiation. Also musculoskeletal atrophy, developmental hypoplasia. So the musculoskeletal atrophy, if you go back to 40, 50 years ago, the radiation to the neck was pretty extensive. That caused a lot of atrophy of the neck muscles. And I knew few people in my life. One of the old doctors that I know had Hodgkin's many years ago. His neck muscles were so atrophied that his neck was so thin, and he had to continue to do workout for the neck and have procedure done because his neck muscles were so atrophied. He had a very thin neck. So that's something we don't experience anymore. Thank God there's a lot of improvement in the radiation, and it's not as extensive, but that's something people who lived with Hodgkin's for so many years, something you have to think about. a lot of those side effects or late effects were not life-threatening, but can negatively affect the quality of life as a survivor. And we all know how that feels. If you look here, this is the cumulative Hodgkin lymphoma mortality. If you look here from this, the green line is from the 60s, the blue line is from the 89 to 2000. So definitely we're not dying from Hodgkin's as much. Very small percentage of people sadly die from Hodgkin's. Most of the people actually have problems, nothing to do with Hodgkin's. And this is all-cause mortality from Hodgkin's lymphoma. And you can see the green line is the all causes. The orange or yellow line is the Hodgkin's lymphoma. And you see it levels off after a few years. The dotted line is the normal population. So you see the difference between Hodgkin's lymphoma survivors versus normal population. The normal population is the dotted line. So there's definitely a difference between Hodgkin's disease survivor and normal population. And the most common, obviously, side effects are the secondary malignancies, cardiovascular disease, infectious disease, respiratory disease. And you can see here, if you look at Hodgkin's lymphoma, the green, seem to be the graph is always the same. It levels off after a while. So beyond 10, you don't know a whole lot of Hodgkin lymphoma deaths. But all other than Hodgkin lymphoma, they have the red line going up high. The solid tumors it started to increase 20 plus years, and after that it goes up higher. And that usually lung and breast are the most common. Cardiovascular disease, which is the blue line, if you notice, ideally start kind of 10 years and above, but it goes more with time. And again, as you know, any chronic illness, the more time you have with it, the more problem you're going to have eventually with it. So especially when you add risk factors like high cholesterol or smoking or your family history, and that kind of increases with time. That's hence the blue line is kind of getting higher with time. Infectious disease, which is the light blue, beyond the initial treatment, or if you had a bone marrow transplant, it's not a big deal. Respiratory also, it's beyond a few years. If you don't have any lung damage, for the most part, kind of not really a major thing. So it's basically malignancy and heart disease are the most two things that we get nervous about in late effect of Hodgkin's lymphoma treatment. And again, the secondary malignancy, and you can divide those into blood malignancies and solid organ malignancies. So blood malignancies like leukemias, and again, the types of the chemotherapy we're using now they're not as leukemogenic. It doesn't cause leukemia in your blood as the older chemotherapies, which is the alkylating agent that we used to use in the past. And that usually happens within the first 5 to 10 years. That kind of goes away after that. So the risk becomes way less after that. And also, if somebody had bone marrow transplant, and so if somebody had radiation to a lot of areas of the bone, the risk of malignancy is also increased, especially leukemias and myelodysplastic syndrome, and sometimes lymphomas, obviously. That could happen too. Breast cancer and lung cancer are the two most common things. Breast cancer for women, especially if you had radiation to the axilla or to the lymph node, is one of the things that we have to keep an eye on and should be recognized, especially if you had it at a younger age. So if you had it between age 10 and 30, you should probably have very, very close follow-up. And I would probably say it's better off to find a breast surgeon or a breast care center that they can follow you with alternating mammogram, MRI, because mammograms below 30, you're not going to do below 30. So MRI below 30, but above 30, mammogram by themselves are not as good either. Remember, when you're younger, your breasts are a little more dense. You're not going to see a whole lot in the breast. So that's why MRI is a little more accurate, but also they're more expensive. The insurance company can give you all kind of problem doing MRIs, believe me. So that's why you got to probably find either a breast center or a breast surgeon. They can watch you very closely, ideally with alternating mammograms and MRI of the breasts. That's something you should probably focus on and discuss with your physician, and probably find a breast care center to follow you with that. There's also breast cancer prevention. not just for Hodgkin's lymphoma, but we knew for years and years and years that taking medication like tamoxifen, despite the side effect that comes with it, does help prevent higher risk breast cancer and Hodgkin's lymphoma patients who had radiation to where the lymph node or the breast, or that's definitely a higher risk. And that should be discussed closely with your physician about using chemoprevention or prevention of breast cancer. As much as I dislike tamoxifen, that might be helpful sometime in high risk patients. Lung cancer. Anybody who had radiation to the chest area, whatever that area, mediastinum, chest, upper, whatever, you're definitely at risk of lung cancer. Some chemotherapies, especially alkylating agent, can give you a high risk of lung cancer. So it's not just radiation, sometimes chemotherapy. Now that risk gets multiplied tremendously if you start smoking or picked up, or you were a smoker before, and that risk increases tremendously. So you have there should be a very strong effort to stop smoking in patients who are Hodgkin survivors who had chemotherapy or radiation to reduce the risk of lung cancer. Thankfully, the treatment of lung cancer for the last 5-6 years evolved tremendously. Still a very deadly disease, and patients who had lung cancer post-Hodgkin's tend to have a little kind of more aggressive form of lung cancer. So it's a serious thing. If you are a smoker, you could probably get a low dose CT scan as screening. They're not going to let you do that if you had Hodgkin's. I don't know if the insurance will pay for it or not. Maybe you can argue that you could probably have it done, low dose CT scan of your lungs. If you had significant radiation in the past, especially after 10-15 years, you probably think about doing a screening CT scan of your lungs. Gastrointestinal cancer, most esophageal, gastric cancer, if you have radiation to the chest, or people who have masses in the abdomen or in the pelvis who had radiation to that area have higher risk of malignancies. And that you should probably, there's also higher risk of malignancy if you had some chemotherapies, and you're going to have probably annual colonoscopies, and you should probably discuss that with your physician. Basically, your cancer screening was supposed to be done annually, or depending on on the risk factors, is a little bit amplified a little bit more, because we all consider a little higher risk, all of us. So you should probably keep an eye on that a little more. Remind your doctor that, hey, is it due to do a colonoscopy? Why do I have heartburn all the time? Should I get a low dose CT scan of my lung? I had radiation in the past. Hey, why am I not having an MRI of my breast? Why not? Those things you probably, again, that's why I'm saying sometimes it's okay to remind your doctor, why am I not doing this? Why not? So that's something you should probably, all of us should be aware. I think raising the awareness of those things helps all of us to prevent those and find them in an earlier stage if they, God forbid, to happen. Now, obviously, one of the biggest things is cardiovascular disease, and that, as we said, multifactorial. Between if you had mediastinal radiation, there's the effect on the heart itself if you had chemotherapy or radiation, but also the risk of heart disease by itself increased tremendously. And as we said, because of other risk factors, high cholesterol, family history, smoking, all that stuff increases risk of heart disease. You should probably have a stress test done at one point, especially 15 to 20 years post chemotherapy and radiation. You should probably have a MAGA scan, or which is a nuclear uptake scan, to see the output of the heart. Make sure you don't have any damage. An echocardiogram is fine, and you gotta observe for symptoms. You have to watch for symptoms, and as long as your doctor is aware of your risk of heart disease, I think you may get more attention. So you always remind your doctor that, I understand, I know you guys, but it doesn't hurt to remind your family doctor, believe me, that, doc, guess what? I had radiation many years ago. Should we look more into my heart? Do I have heart disease? It doesn't hurt, believe me. Endocrinopathy, thyroid is pretty much the most thing, but also infertility, male and female infertility. So we have azoospermia if you had some of the old chemotherapies. Even the newer one, if you had BA cup or intense BA cup or had a bone marrow transplant, that's a problem. So sperm banking is not really very common and it's very expensive. A lot of insurance do not pay for it. So that's a field that we should probably think about at one point. Thank God the most of us do not get those type of chemotherapies. So infertility might not be as common as it used to be. Same thing with females, which is even worse than the sperm banking. You don't find a whole lot of places where you can have you have the ovum harvesting. It's not easy at all. It's very rare to find. It's very expensive. So again, it all depends on the type of the chemotherapy. Excuse me, I'm so sorry. I'm going to turn this off. I apologize for that. So those things you have to remind your physician, even before you start chemotherapy or radiation, or even afterwards. What are my odds of this happening? As we talked about the hypoplasia, musculoskeletal atrophy, you have to stay active. You have to keep working out. Watch out for your symptoms. If you have a lot of arthritis in the neck, especially the posture, how you stand up. A lot of time, if you're trying to straighten up, more than often, sometimes a lot of the muscles in your back, your neck are atrophied on the inside. You're not going to feel it, but you have extra pain in your neck and in between your chest, in between the scapulae, between like the wings. And a lot of those really you're not going to know about them, and you can have extra pain in that area, and usually you stand up funny. So you gotta just make sure to stay active, make sure to straighten up your posture, and that will help hopefully to rebuild some of those muscles. What else? Obviously, osteoporosis. If you had radiation, keep an eye on that. You should probably be more aware of the risk of osteoporosis, which is not mentioned in most of the publications. FYI, by the way. This is the risk of cardiovascular disease mortality. If you look at the green was the 96 to 76, and it is to be compared to 77, 88, compared to 89, 90. If you look, the blue is the most recent one. The green is the oldest one. It's way still higher than the population. We still have significant cardiovascular problems, even in this day and age. And even we all know about it. Even all the screenings that we have, sometimes there's not much you can do about it. It just happens, and you have to keep an eye on it. Regardless, look at this, it's still higher than the population. We are, all of us, higher risk. So we have to keep an eye on it all the time. Remind your doctor and be very vigilant about your symptoms and avoid higher risk factors. That's all those things that, again, it's going to fall on your shoulder again, guys. I'm so sorry to be the bearer of bad news. But as I said before from my start, be your own advocate. There you go. As Kathy said, and as Aaron said, a lot have been published out in outlining the risk and factors of late effective Hodgkin lymphoma. Limited data available on effectiveness of routine surveillance and prevention strategies. Most current screening recommendations in Hodgkin lymphoma survivors are based on their increased pattern over time, which we said basically be your own advocate, remind your physician what you are basically at risk for based on the treatment that you had. You can probably discuss initially with a survivorship program. So find yourself a survivorship program. We all live next to a big city somehow. You can go to New York, to Philly, to wherever. We have a survivorship program here, UPMC in Pittsburgh. They all have survivorship program. They'll direct you what to do. They'll give you an idea what you're supposed to do. It at least gives you a thing to follow, a pattern to follow. So that's something we should probably all be focused on. That's me with no hair and my hairpiece somehow. I'm not sure what happened to that hairpiece. I think I threw it away. But yeah, I had no hair. And this I thought was fascinating. And and out of suffering have emerged the strongest souls. The most massive characters are seared with scars. And you're all scarred. We're all scarred. So maybe it just, it makes you stronger. Just one more joke before I leave. In the Royal Marsden in London, the first day I got my chemotherapy in the lab, they had a sign on the wall said, "Bald is beautiful. Hair is overrated. God created few perfect heads. The others he covered with hair." I thought that was hilarious. That's about it, and that's pretty much my talk. So I'm open for anything you guys want to ask me. Please do.
Well, thank you. I'm going to mention that along with, you said being our advocates and having a list of things that you tell your doctor to be aware of, I just want everyone to remind everyone that Hodgkin's International, in conjunction with Tess Knoll, that's Dr. Tess Knoll, that's on this chat today, created a survivorship care plan, and that is available on hodgkinsinternational.com. So you can find that there.
Excellent. Honestly, I wasn't aware of you guys, your work, and I'm so glad to know that you guys do this work. Amazing.
I'm so glad that we found each other.
Yeah, exactly.
It's good to know that there's also a clinic at UPMC. So that's at the Hillman Cancer Center.
Yes.
Okay.
So
we do have a survivorship program. It's very good and robust and active. And if you guys need any help with anybody, we're more than happy to help.
Okay.
There are a ton of questions and comments. My guess is we're not going to get to all of them in the next half hour or however long you can spend with us. So if it's possible, we could maybe send you some of the questions like in an email and see if we can get them addressed at another time at your convenience.
Absolutely. I'm more than happy. You can email them to me and I'll respond to them like one by one.
Oh,
okay, I just want to mention one comment in particular made by Lori Winterfeld, who I think was spot on. She said Dr. Sholi would be an excellent physician to do a version of this at a CEU program for medical professionals, family practitioners. I couldn't agree more. We need to clone you and spread you around the world so that, that your voice can be heard by many and not just by us. This is probably one of the most important conversations we've ever had as a group. And I can't tell you how much we appreciate your honesty and your support.
Absolutely.
The emphasis on the honesty from both your position as a physician and your perspective as a patient. So thank you to Kathy for finding him.
Oh yeah, it was a neat little miracle how that happened.
Well, thank you. You can say thank you to our common friend, please. She was a wonderful woman.
Yes, thank you.
Do we have time for a few more questions, Kathy?
Sure, if you want to. Go ahead. If you want to ask me anything, go ahead.
Okay.
1973. Look, somebody from 1973. Wow, amazing.
Yeah.
Wish to know what did you get in 1973? Was it mostly radiation? I wonder what it was really. Anyway, go ahead. What do you want to ask, Kathy?
Well, I can't speak for Vanessa. I think she was 73. I was 72.
Oh wow.
And I know that Susie Lee is on the call, and she was also 72. I got cobalt radiation,
exactly,
and then MOP chemotherapy, but I also had a separate radiation at Memorial Sloan Kettering. I had 3 rounds of Hodgkin's within the first year and a half, so I kind of got approached from different angles there. But there's quite a few of us who are 50 years and
amazing.
Over.
Amazing.
Okay.
Go ahead, Kathy. You want to ask me anything?
Sure. Someone had asked if GERD and Barrett's leads to cancer.
Well, in general, yes. It depends on when you have the Barrett's esophagus. Depends on the degree of dysplasia, which basically how abnormal the cells at the bottom of the esophagus. Remember, what happens? You have the chronic acid exposure of the lower part of the esophagus, and that changes the cells in a process called metaplasia from where they're supposed to be to a different kind of cells. So the way they change, the more aggressive they change, the more dysplasia it is. the higher the risk of esophageal cancer that could happen. So if you have heartburn that's constant, or if you're above 50 and you have heartburn, you have to have a scope. You must have an upper endoscopy to look at the bottom of the esophagus. And if you have Barrett's, they could really do a bunch of things for it. They can watch it, they could repeat it, change your medication, whatever they need to do to fix that. But if you do have those symptoms, go have an upper endoscopy.
Yes. Aaron, did you?
There was a question about Vanessa asked, do statins reduce radiation-induced carotid calcification?
I don't think there's research on that, but yeah, I mean, you can, I'm not sure in that in particular. I don't know if they looked into that in particular. Statin by themselves may reduce the risk, but I'm not sure for the radiation induced. I'm not aware of that data, honestly.
Okay.
I'm reading one here about lung scans and mammograms.
Yeah.
And they were told by their primary doctor that it could be too much radiation. So how do you balance that?
Well, if you're at high risk for breast cancer, you're gonna have you have to look for it. You cannot look for it. So MRI, there's no radiation for an MRI. So you can have an MRI every year, every couple of years. I'm okay with that, as long as you can do an ultrasound and an MRI. There's no radiation in that at all. And the low dose radiation CT scan is very, very safe. The level of radiation you get from low radiation CAT scan is very low. So that's something for the lungs. You could definitely do that. But that's why you have to follow probably with a breast health center or a breast care center or a breast physician. Not, with all the respect to family physicians, you may have to go a little bit higher.
Yes.
Kathy Kinga wrote this, and I think we just posted something on this. Are you familiar with the GO-PGX study about genetic testing that may be able to determine who may be more at risk for heart and other issues caused by chemo?
Yeah, it's not something we could use yet. It's all in research, but okay. It'd be nice to find out. It'd be great.
Yeah. Okay.
Yeah, well, Dr. Sholi, I know that I'm in a study that is studying that. If my genetics has any bearing on my cardiac late effects, but I don't know if they're at the end of the study yet.
I understand.
Let's see.
There was a question, Kathy, about John Holland talked about developing increasingly crippling neck necrosis in the last 5 years. I'm assuming that's a more extreme version of what we call our skinny necks or giraffe necks, which is, I mean, we can spot them in each other a mile away.
But that's really something who had probably cobalt radiation years ago. Okay. You don't see that anymore because it's very, very precise, very 3D. It's not, and we're avoiding this large radiation fields anymore. It's very, very, very small and specific. So you're not going to see a whole lot of those anymore. So people who had radiation in the 70s and the 60s and probably early 80s, they have definitely a higher risk of that. It depends how much radiation you got, obviously. And most of the malignancies are dose dependent. That means the more radiation you got, the higher the risk of something could happen. So it's definitely a risk, yes. But I'm not sure, as Erin said, that's an extreme version of atrophy. You're right.
Is there anything therapeutically that those of us who have nothing, okay, you can't exercise.
You can exercise. It helps if it keeps it going. I mean, the last thing you want to do is not exercise and not keep moving, and because those muscles are going to get atrophied more and more and more. So you have to keep doing things.
We did have not questions but comments about when you're speaking about cardiac issues, that we have a number of survivors that are facing open heart surgery and valve replacements coming up. So we wish them all the best.
Absolutely.
There was one other, I don't have it right in front of me, so I'll try and paraphrase it. But I know that one of our survivors has a friend whose son had Hodgkin's lymphoma, and he wasn't, during treatment, they weren't checking for heart problems. And he died shortly from after treatments of congestive heart failure. So currently, what is the protocol for watching patients? that are undergoing that type of chemotherapy.
Well, I mean, it's what we do now is we do a baseline an echo or a baseline MAGA scan. Usually we do an echo. And yeah, again, it depends where are you in your treatment. So we have cardio oncology who actually see the patient up front. And then the file will do the, probably after we finish the chemotherapy, we repeat the echocardiogram. And then if your heart is okay, I mean, you're gonna be okay. And then you have the long-term complications.
Mhm.
But the initial damage to the heart can be avoided if you follow the dose, the maximum dose of the anthracycline you're gonna use. If you have a safe, if your heart function is normal to start with, there are some medication you could use may affect to protect the heart function from heart failure, but it does not reduce the risk of long-term cardiovascular disease. Yeah, it may reduce the heart failure part, but it doesn't reduce the risk of cardiovascular disease.
Okay. There was one other about, they phrased it starting difficult hypertension. And I think they mean to say that, is it due to the autonomic barrelflex failure? They have that diagnosis, they said. Yeah.
Yep.
So I'm assuming that's from the radiation, possibly.
Yeah. Who do you contact for UPMC, for survivorship? Somebody asked that question. If you just, when you call, ask for the survivorship program, they'll set you up with it, really. So just ask for that survivorship program.
Okay.
The question from Michelle about Michelle Lishan about, is direct MOP chemo intervenes responsible for calcifications on tendons and ligaments and permanent nerve damage? Are we talking about peripheral neuropathy, or are we talking about something else?
I'm not sure MOP will give you that, but I have noticed this is not related. I noticed people who had chemotherapy tend to have little earlier onset arthritis, not Hodgkin's patient. All basically you see in all type of patients. I'm not sure MOP is the one to blame, but it's the actual fact that you have chemo and radiation somehow it will make it earlier onset of probably arthritis. That's my personal opinion. That's not a scientific thing. Okay. That's my personal opinion.
Okay.
Anything else jumping out, Kathy?
Yeah, I'm trying to go through them here.
Mostly.
I'm sorry. Somebody about the Royal Marsden. It wasn't McElway. No, it was somebody. I can't remember his name. I am so sorry. I am so sorry. I have a letter from him somewhere, but it's not Tim McElwain. I'm sorry for the. Yeah, I have him. Yeah, no, it's not him. No, sorry.
I hope you are also catching all the thank you and the praise and the this is terrific that is basically every other comment, because
thank you.
It's well deserved.
Thank you.
Yes, so much so. If you have time for one additional one,
one more. Let's go.
Yeah. So this person is it's from Carol. Short of breath and high heart rate, both resting and walking. They had bleomycin and I'm trying to get to my, I just lost the message, sorry.
Bleomycin can cause definitely interstitial lung disease. And if you notice over the last few years, actually, we're reducing the dose of bleomycin. That means when you get ABVD, after four cycles, if you are in remission, you stop the bleomycin. We've been stopping bleo early. First of all, it doesn't have a whole lot of anti-lymphoma effects. So if you're in remission after 4 cycles, they should stop your bleomycin. That's number one. So bleo can cause a lot of lung damage. Go ahead. I'm sorry.
Yeah, I missed the rest of the question. I can't find it right now, but it was something to do with the high heart rate. And I'll just say that I know when I went to my survivor specialist, he said it was typical of most Hodgkin's patients.
That's true.
Because of the radiation.
Can I jump in on my question?
Great, please do.
Yeah, so I had bleomycin 25 years ago, so obviously it went through the 6 rounds. I had a triple bypass 10 years ago, and with the shortness of breath and high heart rate, I'm also on carvedilol. It must not be working anymore. They're going to do an echo and a stress test on me soon. But my question was, should I also encourage them to do a lung function test on me?
Absolutely. 100%. You have to do a DLCO, a diffusion capacity, because of the bleomycin.
Thank you so much.
Sure.
Thank you.
I think we've probably gotten close to the end of what we can possibly tap into
Right.
right now. What do you think, Kathy?
Yes, and I'd be glad to go through the chat and see if they're, I'll compile the rest of the questions and get them to Doctor and
There you go. Somebody
take it from there.
somebody was treating in England, and St. Bartholomew's. So
Oh, yes.
there you go.
There's a few
Vanessa.
people here from England. Yeah.
I guess, yeah.
Yeah. Very good.
All right. If you
Yes.
guys need anything, you have my email, Kathy. Just email me.
Okay, thank you so much.
Thank
Dr.
you
Sholi.
so much. Thanks to
Thank you, guys.
everyone for coming, and we so appreciate your taking the time, Dr. Sholi. It was a
Have a
gift
good
to
day,
us.
guys.
Thank you.
Hopefully we meet again, maybe like 20 years from now. And
Oh no! Next week.
you guys
Thank
have a
you.
fantastic day. It's a great to meet all of you guys. It's really an honor, and I could not be more thrilled and happy. And I'm really like red in the face. I'm blushing. I don't cry much, guys. Don't worry about it. I'm very blushing. It's a very, very special moment to me. You're all like literally family to me. So it's really an honor. So if you guys need me, I'm more than happy to help. You have Kathy got my email. Just email me. I'm more than happy to do anything to help you guys.
Okay, that's
Thank
so
you.
very generous. Thank
Thank you,
you.
guys.
Thank you.
Okay, have a good day. Thank you.
Bye-bye.
Bye.